admit in the ED to see 27-year-old female with possible seizure.
When will I feel confident seeing patients?
It's not so much the interview. No, that I love. The human connection is my favorite part of medicine.
It's the knowledge, the endless facts and symptoms and therapies and drugs and standards of care that seem to change weekly that intimidate me.
I can't shake the fear that someday, in a role with far greater responsibility, I will let someone down and miss something important that I should have known.
I know it's inevitable. Everyone tells me that. It's part of the process. But every day I am one step further, one tidbit of information better than I was the previous day.
I am astounded by how much I have learned in such a short time, and even more astounded by the seemingly insurmountable amount of knowledge I have yet to gain.
I have to remind myself it's a marathon, not a sprint.
Take a deep breath.
Gather your thoughts.
Slow down. Don't be nervous.
I walk down the halls of the Cleveland Clinic, mask tied tightly over my nose and mouth. Freshly ironed, long white coat weighed down by my reflex hammer, the pager clipped to my chest pocket, and a new level of responsibility.
There are probably more fitting things to say, but it's ingrained in me to be free-flowing with apologies, as it has been for a lot of women. So I've been trying to apologize less and reframe thoughts in an appreciative manner. Instead of sorry for the wait, thank you for your patience.
There is a difference between big apologies and small apologies. I haven't witnessed or had to make a big apology, but I can talk about small ones.
Apologizing for a long wait time.
For when I may misspeak or mishear or misunderstand a patient.
Apologizing for things even if they're not my fault.
A surgeon is 2 or 3 hours late because of another previous surgery going long. The patient is upset.
I've been fasting all day, just waiting, so much anxiety.
The surgeon shows up.
I've been waiting a long time.
Patients wait for surgeons, not the other way around.
This is clearly not the way to communicate with an upset patient. Why not apologize? I mean, all he has to say is, I'm so sorry about the wait. I got behind with another surgery and I know this must have been difficult for you. Small apologies only cost us words. But what we gain is empathy and humility. Why not do it more often?
This past week, a 16-year-old patient in my pediatric surgery rotation died. She acutely presented to the ED with symptoms that led clinicians to have a high degree of suspicion of a bowel perforation. She was operated on and non-infected collection of fluid was drained from her abdomen. She remained in PICU for the next several days, and her condition gradually worsened, but there was no definitive diagnosis. The PICU team thought the surgical team needed to intervene and drain her belly again, but the surgery team thought the PICU team needed to medically stabilize her with dialysis. On our way down to the other OR to drain her belly, she died. Each team wanted the other team to fix the problem, and neither team took responsibility. Who should apologize to the family? What would the apology be for? The family wanted an independent coroner for an autopsy because they thought the clinic was hiding something, and they did not trust the doctors anymore. Who takes ownership?
Mr. Smith is an angry man.
I do not like the hospital. I do not like doctors. I do not like nurses. I do not like physical therapists. And I definitely don't like you.
Good morning, Mr. Smith.
Are you doctor number 15,000 coming in to ruin my day?
Oh, no, actually, I'm a medical student, and I definitely do not want to ruin your day. I'd like to hear more about what's going on.
I've already told 15,000 people the same story and the same information. Why do I have to tell you?
We just want to make sure we have the whole story to take care of you in the best possible way.
I don't want to hear it.
So, instead of asking him the same typical questions about his pain, its onset, location, duration, characteristics, etc., for the 15,000th time, I decide to just sit with him.
What are you doing?
Just sitting here, listening to your concerns.
I mean, nobody else running in and out of this room has even ever bothered to take the time to sit and hear me. They're all just talking down to me, a bunch of medical jargon. All in a big rush.
I sit and listen. It's probably therapeutic for him to get a chance to share his frustrated feelings with someone.
I'm discussing the next patient with the nurse. She says her knuckles are enlarged.
Enlarged knuckles? What kind of chief complaint is that?
She's been dismissed as a difficult patient. I think she can hear you. The resident and I walk in.
Why is the nurse making fun of me? And why does the sexual assault, why does it have to be in my record? I want it out now. I'm out of here.
She starts to leave. The resident speaks up, tries to diffuse the situation, trying to focus on the reason she came in, to have a mole removed. I have to say something. It's going to be okay. We'll do everything we can to make you feel comfortable. Is it enough?
This patient has been in the hospital for more than 50 days. He's developed a terrible reputation amongst the whole care team for being violent, disruptive, verbally abusive, and difficult to deal with. His opioid-seeking past colors the lens every team member sees him through, and it appears that there is no end in sight for his stay. I've never had a patient like this before. I don't know how to protect myself from his verbal abuse and show empathy at the same time. So, tell me about yourself.
What? There's nothing to tell.
Well, are you originally from Cleveland?
No, I'm not.
When did you move here?
A few years ago.
Where are you going when you get out of the hospital?
I don't know. I haven't seen my kids in 2 months. I'm in so much pain. Nobody came to see me. There's nothing for my pain.
His vulnerability takes me by surprise. He had never let down his guard and shared his worries before. What had we done as a medical team to make him lock up this side of him? I try to empathize with this man. This man who had been in the hospital for months. Not the opioid-seeking patient who had burned bridges with every single healthcare provider he has had.
A middle-aged woman, HIV positive, with an ulcerated and gangrenous left foot. She's been in the hospital for a few months now with no clear plan of care. Podiatry recommended amputation. Vascular surgery was also consulted, and they recommended hyperbaric oxygen therapy and noted amputation was not recommended at this time. Medicine notes did not delineate a clear plan for the patient. I was seeing the patient as a student on the consult liaison psychiatry service in the hospital. We were consulted because this patient had a history of schizophreniform disorder, and her medical admission was complicated by delirium. But now these acute psychiatric concerns have subsided. I go to meet her for the first time. Why are you crying?
I'm so confused. I don't know what's going to happen to my foot. When I woke up, there were a bunch of doctors around my bed talking about amputating above the knee. I already had the other leg amputated. I don't want my grandchildren to see me with no legs. How can I play with them?
I don't want to leave her alone, but I don't know what to say. Let's breathe together. In, 2, 3, 4, out, 2, 3, 4. I know it's scary. In, 2, 3, 4, out. How do you usually deal with stress? What do you do?
My faith, my family, my brothers flying in to see me. I talk to my mom every day.
Do you want to see the hospital chaplain?
I think so. Yes.
My empathetic bandwidth is limited by what I can't understand. I don't understand mental illnesses like schizophrenia or antisocial personality disorder. They're threatening to me. Frankly, I was scared and kind of ashamed of it. I didn't see these patients as victims of mental illnesses. Rather, I let their illnesses define them. It's the kind of thought process that we have been taught to avoid. One patient I've got to know better over the past few weeks has schizophrenia with depression. He has a history of auditory hallucinations that are intrusive and persecutory, which led to a long history of depression and multiple suicide attempts. I get to learn about his life.
I have a hard time holding down a job because of the voices. Also, I'm homeless, so it's hard to look for jobs. I don't really have any family.
Hearing his story reminds me not to look at patients as their diagnosis. They're human beings.
She's 9 years old, recovering from an appendectomy. And I can't help remember how I felt the day after my own appendectomy as a junior in college. Scared, lonely, and in excruciating pain. I expect this young patient to be intimidated by me. After all, I'm a stranger who she's never seen before in a big hospital with winding, confusing corridors and sterile floors. When I walk in the room, she glances at her mother quickly. I'm a medical student on the team involved in your care. And she looks at me apprehensively. How do you feel?
Much better than yesterday. I ate real food.
What'd you have?
All my favorites, sausage and eggs with pancakes.
And syrup?
Lots of syrup.
We talk about virtual school and the pandemic and what she's gonna eat for her birthday next week.
Mozzarella sticks and cake!
There's just something about her strength and her optimism, the simple joys like breakfast and birthdays. And she shared it all with me. This encounter will stay with me.
The way parents react and handle things, some are very expressive of their gratitude, others lash out and get frustrated with the team. 6-week-old baby with failure to thrive and elevated liver enzymes, continuing to lose weight. Before the patient arrives to the floor, we discuss a wide array of tests. We want to rule out infection, autoimmune conditions, congenital anomalies, and coordinate with the consulting teams as well. I go to meet with the mom and take the history.
When can we get out of here?
Throughout the week-long stay, Mom continues to ask about discharge and seemed uninterested and disengaged from the conversations. I'm frustrated. We are here to support her child and get him back on track, but she seems more annoyed than appreciative.
I can't even feed my baby, and now he's in the hospital. I'm a complete failure.
I had failed to see her perspective and the fear that each patient brings when they are admitted. It might be a normal day for me, but for the patient and their family, it's anything but normal.
I'm on surgery on the hernia team. Clinic days are pretty hectic. 60 plus patients on the list. We only have a minute or two to chart review a patient before running in, evaluating their hernia, and then presenting to the attending. We don't know which patients we will be seeing. We simply grab the next red folder in the hallway and begin. Man, 40s, complaining of a new epigastric bulge. I start by scrolling through Epic, to find the most up-to-date list of their past surgical and medical history. Let's see, this patient, his most recent note was written while recently incarcerated. He was incarcerated for a long time. I wonder why. History of drug use. Oh, this is going to be a challenging patient. I wish I'd grabbed a different red folder. Okay, breathe. Hello?
Hi. Morning.
I walk in the room and actually have the most pleasant and wonderful conversation of my morning. He's very friendly and outgoing, and we have a lovely time chatting.
I have a new job painting houses. I just love it. Very rewarding to step back and look at a fresh coat of paint, Yeah, I gotta get this surgery done soon. I got a couple of houses to finish up.
I definitely had a bias and a fear walking into the room. It shouldn't have surprised me that this patient was a very kind, gentle, and heartwarming person. I'll think of him for a long time, reminding myself not to judge a person before even meeting them.
To add an extra layer of difficulty, we're all wearing masks and shields. My tools of body language and facial expressions are limited.
It's hard to connect through a face mask and a fogged up face shield.
COVID-19 is a place of common ground between practitioners and patients.
The playing field is more level when we discuss the situation. We are able to share feelings of concern and about how our lives have been turned around a bit. Patients have become even friendlier.
I can't imagine how you're managing as a med student.
They tell their stories.
My son is about your age. He had to move back home.
I work at a warehouse,
He got
but
laid
I
off
don't think
because-
they're following good safety precautions. And
We're all having
We're
to
all
isolate
overworked.
from each other at home, hide in our bedrooms.
Patients seem more comfortable discussing their problems at home, their mental health, their family issues. I understand. I appreciate that I can listen. Even through the mask and the lack of handshakes, it's one of the most human-to-human interactions I've had in medicine.
why don't some patients follow medical advice? Why stop taking a medication? Why cancel appointments?
Perhaps they have experiences that cause them not to fully trust providers.
Perhaps no one took the time to fully explain the importance of medications or procedures.
Perhaps no one took the time to ask the patient what their goals for care looked like.
I wish I had taken a step back to ask the patient what she thought about her symptoms.
How does it make you feel?
What are your fears?
What are your hesitations?
A patient who had suffered with ectopic pregnancy, she presents to the ED. The OB-GYN attending on call gives orders to prep her for the OR without even seeing or reviewing a thorough history. The patient recently discovered
I have factor 11 deficiency.
she shouldn't be undergoing this procedure. It's too risky.
I wouldn't have even gotten pregnant if I knew it was high risk. I don't know what to do. One doctor tells me one thing, another doctor tells me something else. Yeah, I've been here all day waiting for surgery.
But the surgery is called off when the team realizes it isn't the correct course of action. She's treated medically. She's so frustrated. What can I say?
I know I'm dying.
What are you supposed to say to someone who is depressed because they're dying?
I can barely talk or eat.
I'm at a loss for words. I can't make unrealistic promises like, I'm sure you'll gain your strength back. It's empty. I'm helpless, ineffective. What are you supposed to say to someone who is going to die?
This isn't a way to live.
It turns out there is some good that can still be done. We can make the patient's life more comfortable. We can help stabilize his mood and decrease his fatigue with various medications so that he can think more clearly about his end-of-life goals and have more energy to do activities he enjoys. We can ensure that he maintains as much dignity as possible throughout this entire process. It's a far cry from a cure, but it's also more than nothing.
The human connection is my favorite part of medicine.
Every day I am one step further, one tidbit of information better than I was the day before.
I am astounded by how much I have learned in such a short time.
I have to remind myself it's a marathon, not a sprint.
Take a deep breath.
In, 2, 3, 4.
Gather your thoughts.
Out, 2, 3, 4.
Slow down and don't be nervous.
I can do this.
Trust your instincts.
This is what I'm meant to do.
This is what I've been waiting for my whole life.